Infantile Nystagmus Syndrome presents an immediate and highly visible challenge: the constant, involuntary oscillation of the eyes. This movement doesn't exist in a vacuum. When a patient tries harder to focus or experiences psychological stress, the oscillation actually speeds up. Everyday visual tasks become physically exhausting. However, patients have an angle of gaze where oscillation quiets and visual acuity peaks, the null zone. Because this zone is rarely straight ahead, patients naturally compensate, adopting severe face turns or head tilts to align their eyes with that angle. The physical cost of these postures defines the clinical reality of INS, the massive strain required to constantly align the head just to navigate the world. We start with conservative options. Correcting high astigmatism or prescribing prisms can help, and systemic medications like gabapentin are sometimes trialed. But for severe cases, optical devices hit their limits, and drugs often cause generalized sedation rather than targeted relief. That leaves surgery as the primary tool. Surgeons aim to physically shift that null zone into a straight-ahead position. Here is the friction. Despite being our most effective tool, no randomized controlled trials universally prove one surgical method is better than the rest. Surgeons are left to choose from 6 distinct procedures, ranging from mild tissue adjustments to highly aggressive anatomical reconstruction. Success requires the clinician to carefully evaluate the patient's specific compensatory habit and match it directly to the exact structural severity of the surgery. Let's look at the first presentation, a patient relying on a severe, constant horizontal face turn. The standard approach here is the Anderson-Kestenbaum Procedure. The surgeon targets the specific pair of rectus muscles driving that head turn, recessing them to manually drag the off-center null zone to the front. The cost of this mechanical fix is high. You are permanently altering multiple, entirely healthy eye muscles to treat an issue rooted in neurological innervation. Now consider a patient presenting with extreme chin depression or a distinct head tilt. In this case, horizontal surgery won't help. We use vertical recti surgeries, recessing the inferior recti for chin depression or slanting the oblique muscles to adjust the cyclotorsional effect for a head tilt. These are highly targeted anatomical adjustments, but they do absolutely nothing to calm the standard horizontal nystagmus itself. These postural surgeries work as ergonomic repositioning. They ensure the patient's natural, resting posture becomes their best seen posture, even while the neurological oscillation continues. Some patients need a broad reduction in the actual intensity of the eye movement, regardless of how they hold their head. For this, we look at maximum retroequatorial recession. This is a massive intervention. The surgeon takes all 4 horizontal recti and moves them entirely around the globe's equator, recessing the medials by 10 millimeters and the laterals by 12. This permanently alters the resting tension of the entire horizontal ocular motor system to forcibly slow the eye down. A highly specific subset of patients present with what we call convergence damping. Their nystagmus naturally slows down, but only when they cross their eyes to look at something up close. To exploit this, surgeons use artificial divergence. They intentionally create an outward eye turn, an exophoria. To see clearly and avoid double vision, the patient is forced to constantly cross their eyes inward, triggering that natural calming effect. The downside is invisible but significant. The patient must constantly exert their fusional convergence reserves. This continuous muscular effort leads to chronic visual fatigue over time. If the goal is a direct reduction in the eye's physical oscillation, the patient must absorb either severe biomechanical disruption to their eye muscles or perpetual muscular exhaustion. On the absolute mildest end of the spectrum, a surgeon might attempt to reduce the oscillation without permanently changing the eye's resting position. This is the tenotomy procedure. The surgeon simply detaches the eye muscles and immediately reattaches them to their exact original insertion points. No tissue is shortened or moved. Because nothing is anatomically altered, the clinical literature heavily debates its efficacy. Many researchers suggest a strong placebo effect is driving the reported improvements in these patients. Then there is the absolute most destructive option, reserved strictly for severe, intractable nystagmus, where every other intervention has failed. This is a myectomy. It involves the complete or partial removal of all 4 horizontal rectus muscles from the eye. By removing the muscles, you forcibly stop the horizontal oscillation, but at the cost of permanently destroying standard horizontal ocular motility. When you look at the extreme edges of INS surgery, you are forced to choose between relying on unproven neurological placebo effects or committing to irreversible anatomical destruction. The best surgery exists relative to the patient. It depends entirely on the specific compensatory mechanism they use to survive their daily life. If the dominant presentation is a painful head turn or tilt, you target the Anderson-Kestenbaum or vertical surgeries to physically center that null zone. If their eyes only calm down when converging to read, artificial divergence becomes the strategic play to lock in that stability. But patients must be counseled on the reality of these interventions. They are trading an underlying neurological symptom for a permanent physical alteration of their anatomy. Clinicians should prioritize the reduction of effort to see over the goal of achieving a motionless eye. Navigating this space without strict randomized controlled trials means post-operative evaluations must carefully account for the placebo effect. Evidence-based practice for INS requires a precision trade, matching an intervention's permanent anatomical side effects to the patient's most urgent functional deficit.